You are now listening to the Mood for Thought podcast.
It's really refreshing to speak to someone like yourself who has such a variety of research interests, including things like autism, ADHD, contact disorder, personality disorder. Maybe we can start if I could just ask you a bit about your background, sort of your journey through psychiatry.
Yeah, okay. So before I did medicine and psychiatry, I did a degree in theology and religious studies at Cambridge. And in the course of which I became very interested in the relationship between culture and cognition and brain function. And at that time, I did an undergraduate dissertation on a theory, a neurocognitive theory of religious experience at the time. This was in the mid-1980s. And when I completed my studies, I was initially planning to do a PhD in biological anthropology to pursue this field of research further, which at that time was called neuroanthropology. But for various reasons, I decided to go into medical training. I think partly because medicine gives a very comprehensive understanding of the human person, both from a biological and psychological point of view. And also there was a practical side to medicine, a clinical side that was interesting. So I thought medicine seemed like a good combination of science and practice, and hopefully a humane discipline that would help me to find out about people in a way that's interesting.
Yeah, I mean, it is the case that I guess what clinical medicine forces you to do is actually contend with the nature of the world as it is. And like you say, it's very practical. So I guess it's a bit less, it's a bit more where the rubber meets the road. And you can actually see not only how are these ideas sort of in academia, you know, what interest do they have on that level, but also how can they be of a very practical use to a person in an everyday situation.
Yes, I'd agree with that. Well, I think medicine is a practical discipline. So as a practical discipline, you have to make decisions on the basis of the information that you have. And often that forces you really to think very carefully about what the influences on people's behaviour are, what influences on their disability and distresses, and what you can do to intervene in a practical way to help people. But the other good thing about that is that people are complex, and they make you realise that your theories don't always fit. So they broaden your understanding of what people are just by contending with the complexity of what human beings are.
Mm-hmm. It forces you to constantly have a standpoint of curiosity. You can never decide that you reached an end point because people are so complex. You always have to keep that open mind. You always have to be willing to revise your ideas. That's what I like about it, revise your ideas, ingest new ideas.
Yes, I'd agree with that. And actually also of course, one of the characteristics of human beings is that we're embedded in society and culture and history, and that introduces variation into what we are too. And so we can see commonalities in human beings across cultures and periods of history, but then there's also the locally distinctive characteristics that people have. And obviously working in a place like the UK and a place like London, you see people from all over the world. And so there's a constant learning process to try and understand how their particular biography and background has influenced how they meet the world and the types of difficulties they experience.
Of course, and I guess that's one of the major problems that psychiatry has faced over the years. We often try and deal with an idea of sort of what it means to be normal, or what's the kind of standard of health against which we should be comparing people who we judge to be mentally ill in some way, shape or form. How do you think about the relationship between these cultural factors and mental illness?
Well, I think it raises quite deep questions, really, about how we think about psychopathology. I think there's an important question about the types of experience that people have. We could call that a phenomenological question, and how culture influences the types of experience that people have. And also whether the types of experience that people have that we can describe in the language of psychopathology, of descriptive psychopathology, such as auditory verbal hallucinations or delusions of control, whether they are intrinsically linked to distress and disability, or in actual fact whether some of those variations in experience just form part of culturally valued and culturally cultivated or religiously cultivated or sanctioned forms of experience, variations in experience. So I think there's a question about interpretation, understanding at that level. So I think this set of issues has been recognised for a long time. So, for example, in the 1980s, there was an influential book by Roland Littlewood and Maurice Lipsedge called Aliens and Alienists. And really, the whole thrust of that book was to encourage psychiatrists to try to take into account the cultural context and background of people as an important influence on the types of experience they have and how they react to stress and what the resources are available locally in order to support people in their adaptation to distress. And perhaps to make psychiatrists who are very often from a different cultural background from their patients to think carefully about whether what is being encountered is a typical presentation of a mental disorder, or whether it in fact is something that it might superficially resemble a psychiatric disorder, but might in fact represent some kind of other acute response to distress which has its own characteristics and can be locally managed in a way that doesn't necessarily involve a very high level of involvement of psychiatric care or treatment. So I think that kind of approach was important. But I think also there are questions about pointing towards what the constraints or influences on people's experiences are. And if we think that there can be variations in experience which in some ways resemble the types of experience that occur, say, in psychosis or in dissociative psychopathology, but whether they don't in fact represent illness in their own right, then that raises an important question about what causal influences on those experiences are shared between psychopathology and religious experience, for example, and what are different, unique to psychopathology and religious experience. And so that's one of the areas that we have been thinking about and researching.
Yes, and I think in our sort of modern, very rational Western world, often we try and think about more religious type experiences in this context. So are they just these sort of psychotic experiences? Could they be explained by psychopathology? But obviously the point you raise is quite different, that these experiences might be distinctly different. They might have some similarities, but I think it's probably important to point out that they have important differences as well. What do you think are the primary differences between what someone would call a religious experience and a more typically psychopathological experience, like a psychotic episode or a dissociative episode?
Well, I think as a point of departure, I think we'd have to recognise that religious experience itself is an umbrella term, so that encompasses an enormous variation in types of experience and forms of sensibility that human beings have. We can start to think about certain characteristic types of religious experience that have been reported quite commonly in different settings. For example, mediumship or prophecy, in which a person is understood to be a vessel or a medium through which a supernatural agent, a god, or gods, demons, spirits, ancestors are communicating, and in which their normal sense of self is suspended or absent, and in actual fact it's another agent communicating with them, controlling their speech, controlling their movement. So that's a very fundamental form of religious experience. It's at the heart not just of mediumship or oracles in many societies, but also in prophecy and the whole broad category of revelatory experience. So it's how many human beings think about how information from the supernatural realm is communicated into human life. So you might say, well, there are certain respects in which those types of alterations of self-experience can, in fact, be described in the language of psychopathology. So, for example, if it is the case that you are communicating thoughts or ideas which are communicated, inserted into your mind by a supernatural being, then in the language of psychopathology that can be called thought insertion. Or if it is the case that your actions are controlled by a supernatural agent, such as you're writing information down, that they're controlling your hand, say, for example, in the revelation of Scripture, then that can be described as alien control of movement. If it is the case that your identity is substituted for a supernatural agent, then in the language of psychopathology that could be described as dissociative identity change. So the point there is that the phenomenological language of descriptive psychopathology is in fact very accurate in describing very precise, specific ways in which the normal experience of selfhood can vary. But of course, the mere fact that you can describe experiences as varying in those ways does not in itself imply psychopathology. And I think that's the point here. So that's why I think a fuller understanding of the context within which variations in experience occur, the significance attributed to that locally, and whether or not those experiences are associated with disability or distress, or whether they are culturally valued or sanctioned or recognised is clearly important in working out what's going on.
Mm-hmm. So you're pointing to the idea that because the language that we use in psychiatry can easily map on to these phenomenological experiences quite well. And I guess the danger is that that would lead one to believe that they're one and the same. But you're making the case that no, they're not the same, that despite these sort of superficial differences, there are actually deeper ways of telling the two apart. So things like how much is the person actually being disabled by the experience that they're having in their day-to-day life? How much are they functioning on a sort of socio-occupational level, things like that? Am I correct in saying that?
Yeah, so these are all clearly very important considerations, and they're very practical considerations as well, because I think from a practical point of view, there are all kinds of variations in experience that are going on all of the time in the population as a whole, only a tiny proportion of which ever come to the attention of psychiatrists. And that is normally in the context of distress or disability or breakdown, if I just use that lay term in general sense. But all of those considerations are clearly important in trying to make sense of what's going on and respond to it appropriately.
Do you think that in the case of genuine psychopathology, for example, a case of schizophrenia, do you think it's possible that a culture that is more accepting of those the phenomenon of schizophrenia and are able to build a cultural context around their psychopathology? So, for example, if someone were hearing voices and perhaps in their culture they were thought of as being some kind of oracle, like you mentioned. So it's kind of the reverse of what you're saying. So rather than religious experiences being misidentified as psychopathology, do you think psychopathology could be incorporated into a culture in a way that's acceptable, in a way that could reduce harm, things along those lines?
I think in general terms the answer to that is yes, but I think that question has to be quite carefully handled for a number of reasons. I do think that if we think about where psychiatry is a discipline, where we are now, psychiatry, I think, has always had an uneasy relationship with religious experience, and I think there are historical and cultural reasons for that. So psychiatry as a discipline really started to form in the 19th century in an age of secularization in which most of the practitioners were not religiously observant or no longer religiously observant. And I think also actually as a discipline it formed in Western Europe and North America predominantly, in more ethnically and culturally homogeneous societies. So the actual assumptions of the people doing the psychiatry and the types of worldview and forms of experience that they came into contact with, I think in general had its own very particular historical and local characteristics. And I think one of the consequences of that is that psychiatrists in general have never really operated with a substantive concept that religious experience had value, or that, and when I say value, what I mean is not necessarily, this is not a point about the truth value of religious experience. It's not a point, it's not an argument so that religious experience is necessarily imparting important information about the world that we should all take heed of. That's a separate question. The point I'm making is really about the locally perceived value to that person or to a relevant community. And also I think a fundamental point is to what extent the variations in experience actually conform to local expectations, because this I think is also relevant to the question of how to evaluate alterations of experience in somebody from a different cultural background who is acutely distressed. And this actually goes back to one of the points that was made back in the 80s by Lipsedge and Littlewood in their book Aliens and Alienists, is that I think one of the criteria for picking out whether or not what you're encountering is an episode of illness is whether it's not just to do with the resemblance phenomenologically between the type of experience somebody is having and within a conventionally recognised mental illness, but it's also to do with the level of distress, the disability, and whether or not the way that person's experience of the world is unfolding is also regarded as locally problematic and falling outside what would be recognised as expected within the context of local religious experience. And I think that having that additional perspective is very important in making sense of what's going on. One might also talk actually about the time course of experience as well. So it's very often the case that culturally influenced or sanctioned religious experience will occur within particular contexts. So for example, it might occur within the context of worship. So if you think about a Pentecostal church and people speaking in tongues, for example, or if you think about one of the African prophetic churches where people will prophesy in the course of worship. The point about this is that there is a shared collective context within which alteration of experience occurs. And there is a kind of, if you like, there is a temporal structure whereby there are certain types of places within which altered self-experience occurs. And that alteration experience does not intrude or obtrude into other areas of life in a way which interferes functioning, like the ability to work or the ability to look after children. And I think when you get a kind of uncoupling of altered experience from the context in which it's locally recognised as it should occur, then I think that is one of the markers of saying, well, actually this is what we're dealing with here is properly thought of as an episode of illness. But even there, actually, I would say that some of the decisions about whether or not an alteration experience or sensibility, some of those decisions about whether or not it represents valid religious experience or psychopathology, I think some of those decisions are actually inherently very difficult to make. And what we may be really bumping up against are two different frameworks for thinking about human experience. The reason I say that is because it is possible for people to be religious innovators or to have a particular standing within religious terms in which they are recognised as having a unique alteration experience or type of perspective on the world, which is not necessarily shared with everybody else. And this might be part of the pathway by which people become recognized as shamans or mediums or oracles, depending on the cultural context, or prophets. And so it's by the very nature of those types of experience that they tend to belong to particular specialist roles. And so I think there is some important research that has been done in anthropology on this question. A lot of it actually is being done by a professor of anthropology at Stanford called Tanya Luhrmann, who's written very well and is doing important research on the cross-cultural variations in psychosis and wrestling with these questions really about when does an episode of altered experience embedded with this in somebody's biography, when should we think about that as illness and when should we think about that as part of the process of becoming a ritual specialist of one kind or another. And so, for example, a common way of thinking about the process by which somebody becomes a shaman, for example, or a ritual specialist, is that there may be an episode of mental illness or an episode which is locally recognized as mental illness, but which is simultaneously interpreted as a kind of spirit attack or contact with the supernatural world, through which that individual then learns to master their encounter with that other realm, or alternatively they are chosen by agents within that other realm to be a vehicle through which relevant communication to the local community exists. So I think in talking about these cases, I think it's very important for me not to operate with a very binary distinction between mental illness and religious experience, culturally appropriate religious experience. I think some of this area is inherently difficult, not just for the Western psychiatrist, but actually also for people within those cultural settings as well, in order to make sense of what's going on, and whether this is a staging post. The episode of apparent illness is a staging post in somebody's progression into a more stable role within the society in which they have access to other forms of understanding, or alternatively, whether this represents something which is inherently disabling and distressing and does not carry social value.
Mm-hmm. Yes, so it's clearly very complex, and it's something that has to be tackled on a case-by-case basis. I think it's probably also worth mentioning that even in non-religious contexts, I think people who suffer an episode of mental illness of one kind or another, be it psychosis, depression, anxiety, often if it's framed in their mind in the correct way, it can be profoundly important part of their life. Because it brings you in contact with your limitations as a person, the limitations of your psyche, just that immense difficulty can be something which really consolidates the way you look at the world. It can help you. It can be a touchstone that you take with you for the rest of your life. I think I did another podcast with Dr. Russell Razak, who wrote a book about this. I forget the name of the book, but the central thrust of the book was that these intense moments of difficulty, be they mental illness or otherwise, can be really important stepping stones in our life to the profound, to ideas which can ultimately push us forward.
Yes, I'd agree with that, and I think the point that you make actually also draws attention to some of the limitations of the traditional concept of disorder or disease that we've operated in medicine, or at least that we have applied from medicine to the domain of mental health. Psychiatry does not in general have a well-specified theory of human flourishing or wellness. So illness is considered to be defined by the presence of symptoms which imply a departure from normal experience in one way or other. But the approach tends to be, with respect to classifying variations in experience, it tends to be, from a phenomenological point of view, quite taxonomic. So it's very much preoccupied with the description of the formal characteristics of certain alterations in experience. It's relatively insensitive to context, relatively insensitive to biography, relatively insensitive to history.
And it tends to be categorical.
And so that rather atomized conception of the person, whereby a disorder is defined by the presence of enough atoms of experience to amount to an episode of depression or to amount to an episode of schizophrenia, I think has clear therapeutic limitations, because I think the point that you're alluding to is that an episode of illness considered in the context of somebody's life, their unfolding biography, can actually teach them a lot about themselves. It can teach them a lot about the world. It can teach them a lot about other people. And so I think having a more processual view, and perhaps taking some of the ideas which are more commonly articulated within psychotherapy, but which also are present within elements of psychiatric theory as well. Thinking, for example, some of the ideas stemming from Jung about the idea that the human mind should be viewed as a self-regulating system, whereby episodes of illness can be viewed as arising from an intended adaptation to an internal or external aspect of the world, but which may not be fully successful as an adaptation, but which may nevertheless teach you important things about yourself. I think that type of perspective can be very helpful. So it's a bit like the conclusion to the Samuel Taylor Coleridge's Rhyme of the Ancient Mariner. So the ancient mariner, the poem concludes, "A sadder and a wiser man, he rose the morrow morn." And I think, so there is much that illness can teach you. It can also actually teach you not just the frailty of the human condition, but it can also point to what you should value about the human condition as well. And I think this is an important point when thinking about religious experience too, because there might be a temptation to think that in the context of religious experience, what religious experience is telling people is something about ontology. It's telling them a new set of ideas about what exists in the world. For they discover the reality of a supernatural agent, or the supernatural agent tells them to do something. In actual fact, I think the value of illness to human beings, perhaps in a broader sense, can be not necessarily that it changes your notion of what exists in the world. It's not a shift in ontology, but it helps you to think differently about what exists in the world and in your own life.
It sort of broadens your range of different states of consciousness. So it makes you realize that different ways of experiencing the world actually exist. Because before you have experiences like that, you're not even aware of the kinds of conscious experiences that you're not having. And then you have an experience like that, and all of a sudden your worldview is opened up that much more.
Yeah, I would accept that in general terms. I think we'd all recognise, though, that the not all variations in experience are good variations in experience. I think this is a very important point not to lose sight of when talking about the relationship between religious experience and psychopathology. Because actually I want to be clear about this, that I don't want to underestimate the distress and disability associated with mental illness, properly so called. And if, for example, we do think about mental illness as something that we can learn from, it's also, that's true, but actually sometimes there may not be, mental illness is the kind of thing from which people just want to recover. And there may not be grand conclusions that they can draw from it, but it's just something that they need to get over in order to improve their lives and get on with their lives. So I don't want to impose a single framework for thinking about mental illness. I think that would be a profound error. And actually I have to say that that a lot of what we encounter as psychiatrists really does present itself very much as a disorder. which we are helping people to move beyond or to recover from.
Yes, so that's an important point. So I suppose what you're advocating is that we just, in psychiatry, create a bit more space to allow for the view of the person actually experiencing the illness, and just give them that, I suppose, that flexibility to experience it whatever way they seem appropriate, while at the same time being responsible and providing the care that they need.
Yes, I'd agree with that. I think there are 2 points here, Amai. I think part of this perspective, I think, which is trying to locate psychiatry within a broader recognition of cultural variation and influences in experience and sensibility, is just to perhaps make psychiatrists more open to considering that not all of the variations in experience and apparent distress that they encounter necessarily represent instances of mental illnesses as described in our diagnostic manuals, even if there can be overlaps. So I think it's a broadening of a perspective about the variation experience and about the different meanings and values that can be attached to variation experience, and a broader conception of the biographical, cognitive, neurobiological and social, cultural influences on motivating these variations in experience. So that's part of what this is about. But I think also when we do think about episodes of distress and disability, which do properly fulfill the criteria for an episode of mental illness, I think in those cases we again have to be open-minded and strike a balance between recognizing that some of those episodes can be viewed as part of somebody's life journey, whereby they are confronted with difficult circumstances, they're adjusting to those, they're learning and adapting, and those episodes of illness arise in the context of that. But actually other episodes of illness don't behave like that. They behave much more like a disease, in the sense in which there is an impairment arising from some breakdown of the basic systems that we rely upon to function day to day.
Could you give me an example of that?
Yeah, I'll give you an example. Well, of course, there are many. I mean, I think there are really quite prototypic examples of that which fall within the remit of psychiatry. We think about some of the dementias, for example. So, a progressively deteriorating condition which deprives people of their normal functioning in a way that can be very cruel. So that would be one such example. But actually, I think many cases of depression can function like that, of melancholic depression, that you see somebody with a recurrent depressive disorder who becomes very unwell, very disabled, very distressed.
And very quickly often.
Very quickly, and which one has to say really does behave like an illness. That they need help to recover from.
It can be very physical, like they might have their sleep disturbed, their appetite disturbed. They can exhibit a phenomenon known as psychomotor retardation, where all of their body movements are actually slowed down, poverty of speech and thought, where the stream of consciousness is slowed down, the speech is slowed down.
Yes, absolutely. And also, I think within psychosis, within schizophrenia, we will see people who are profoundly disabled by psychosis, and again, in which the actual content of their delusions, for example, the types of experience they have, are inherently distressing, and which it's very difficult to discern within that any form of interpretation of the world which could form part of their subsequent adaptation to life, or which they could teach them lessons. That's not necessarily the case for all psychosis. I know that there is a concept of spiritual emergency, and that sometimes under conditions of profound stress that people can develop psychotic episodes, and they may recognize subsequently that there were elements of those experiences whereby they did lose contact with reality, but within the context of that experience, people can also say, well, I learned things about life in the way that we were talking about. And some of what they learn about life it may involve a change in their view of the world. It may be that they become religious in a way that they were no longer, they were not previously religious, or they may lose religious faith as a consequence of psycho. It can go both ways. The relationships are complicated. But I don't want to say that every episode of psychosis is not something from which people can learn, but I think some episodes of psychosis very much behave like disorders, and it's clearly very important to be able to help people and intervene as necessary to help people into those circumstances.
Yes, especially in cases where psychosis is drug-induced, which is very common, especially in London. It's well known that drugs like particularly amphetamines and cocaine, which directly increase the levels of dopamine, which is a neurotransmitter in the brain, leads to a psychotic episode. And we know that, or we have a strong theory that in cases of schizophrenia, it's also dopamine that may be implicated in producing some of the symptoms. So, like you say, in some cases it comes across, very biological, very much like a disorder with the characteristics of a disorder.
Yes, I'd say that, but actually also I would equally be cautious about assigning psychopathology to something for which the biological underpinnings are well specified. I do think there is always chemistry and electricity going on in the head, which supports whatever forms of experience that we're having, or at least that's our operating assumption about the world. And it clearly is the case that we can identify biological correlates of certain types of mental disorder which are different from normal functioning, correlate well with the disorder, and alter or remit in tandem with treatment of the disorder. And so it therefore behaves like quite a biological condition. But actually I would still, in general terms, I would still be cautious about isolating biological changes too much from the total context within which the person is embedded. For example, it's possible to have an episode of depression precipitated by losses or stresses, which can then be correlated with changes in brain function. But in actual fact, without the losses or stresses, the changes in brain function would not have arisen. So it's about re-embedding the person within the world and recognizing the full set of constraints which influence the formation of experience.
Yes, so understanding the biology alone, it would be difficult to draw conclusions just based on that. Biology is merely one level of analysis on which you can understand and experience.
Yes, and a very important level of analysis. I mean, the brain is the organ of experience. But equally, I think one of the changes that we're seeing, certainly in the type of research that we're doing in the Cultural and Social Neuroscience Research Group, but perhaps more broadly as well, is a movement away from a style of explanation which really originated with the lesion deficit method in the 19th century, which basically sees mental disorders or neuropsychiatric disorders as caused by a lesion in the brain. And when I say lesion, you can think of that in very concrete terms as damage to a region of the brain. But actually that idea has persisted in terms of the attempt to specify alterations in brain structural function, which may be more subtle and only detected through large-scale neuroimaging study designs, where you measure brain activity or structure in lots and lots of people, average results, and compare them to typically developing people like a control group. And that allows you to say, well, person with condition X has these sorts of changes in the brain. The point about that type of explanation is that it points back to the brain as the primary level of explanation, and therefore experience is viewed as a kind of dependent variable upon brain function. The point that I would make is that if we think about re-embedding the person within the world, within the social world, within development, then we can actually see how the influences on brain structure and function developmentally or acutely are important to the causation or emergence of an episode of psychiatric illness, but they don't occur in a vacuum. There are a broader set of historical, developmental and immediate constraints in the environment which influence the onset, course and character of episodes of mental illness. And actually, in fact, in some cases, I think the appropriate way of thinking about the relationship between the brain and experience is that changes in belief, expectancy or attribution produce changes in experience through effects on brain function.
Yes.
So it's actually changes in belief and expectancy and social context and practice can alter experience through effects on brain function, but the brain function would not alter without the requisite changes in attribution, belief, interpretation, expectancy, social context.
Yeah, so the biological forces aren't acting in a vacuum, like you said. They're interacting with and being affected by things which we would consider social and psychological.
Yes.
I mean, I think we've been talking a little bit about religious experiences, psychosis, profundity, and we mentioned drugs as well. It would be hard not to talk about, to throw a spanner in the works, about psychedelic drugs which we know and we can see on your imaging are acting on a biological level, yet have this very consistent capacity to induce experiences which are considered profound, life-changing, transcendent, etc. What do you think about psychedelics?
So I think there are several questions which arise, really. I mean, I think there are quite basic questions about how psychedelics work, how they contribute to alterations in experience. And then I think there are a separate set of questions about what their potential therapeutic value is or is not. I think if we take the first question first, I think there can be a tendency to think of of a psychedelic drug of one kind or another as producing alterations in experience at a uniquely neurophysiological level. But in actual fact, there is an arc of explanation going back to the first wave of psychedelic research in the 1960s and 70s, which at that time was influenced by an emotion researcher called Stanley Schachter, who originated the label theory of emotional states, which emphasizes the importance of cognitive appraisal on shaping the content of psychedelic experience. So that, again, points us back to understanding the role of context, expectancy, attribution, the broader world in which the person is embedded in shaping the nature of psychedelic experience that a person have and the difference it makes to them subsequently, the reception of the experience.
So by cognitive appraisal, do you mean how they contextualize the experience?
Yeah, so the types of concepts that you draw upon to interpret the nascent changes in experience that arise from the administration of the drug. So, for example, and I think this is important research that is yet to be done systematically now within the current phase of psychedelic research, it is understanding the effect of prior expectancy and beliefs about the world on the content of experience. So, for example, the administration of psychedelic drugs like psilocybin may be associated, or have certainly been reported to have been associated, with unitive mysticism type experiences in which there is a attenuation of the sense of self as separate from the rest of the world, separate from other people. But equally, the administration of those drugs can be associated with experiences, very vivid perceptual experiences of encounter with supernatural agents. So they can occur within the same episode, but I think part of the research that we need to do is to understand, for example, the use of mescaline or other psychedelic substances which form a part of an indigenous pharmacopoeia, say within the South American context, when people take those drugs within a ritual setting, where under the group direction, prior expectations, the tutelage of a shaman, people encounter the types of being that they believe belong to their worldview. And so there's a question here for people who are outside that culture and outside that context. When you administer the same drugs, do they have the same types of experience, or to what extent are the sorts of experiences influenced by prior expectations and belief? And one way of thinking about prior expectations and belief is that if there is an absence of a strongly specified local theory about what should happen when you take the drug, how does that change the nature of the experience you have? So it may be the experience you have is not one that's characterized by encounters with jaguars that have a particular local attributed significance, but by different sorts of experience, and perhaps more of these unitive types of experience that seem to be reported by in the more recent research in weirds, Western educated, industrialized students, basically. There is a precedent for this kind of research, and that really goes back to the 1960s, to the so-called Marsh Chapel experiment, which is when LSD, I believe, was administered to college students in a church setting, and within that context they had more religious type experiences. So again, it's a sort of manipulation of context and expectancy. So these are important questions, I think, about what the interplay between cognitive, social, cultural and physiological levels of explanation are in the evocation of psychedelic experience. The question, I think, of what the therapeutic role of psychedelic drugs are, I think that, again, there is not one answer to that. It's going to vary with the drug. It's going to vary with the dosage. It's going to vary with the way that it is embedded within a therapeutic intervention. It's going to vary with patient characteristics. It's going to vary with the type of illness or episode of distress that a person's experiencing. So I think it's very important to take a step back from a global view that psychedelics are good or bad, and just fractionate it really into probably what are dozens of questions, quite specific questions, rather than a yes or no.
So the impression I'm getting is that much research remains to be done to answer these very, very specific questions.
Yes, and I would say that, and I do think, I have to say, I do think caution is warranted in the use of these drugs. It's not to mean that they shouldn't be evaluated, but I think a sort of exhilaration about the possibility of the rediscovery of psychedelics could be very unhelpful to people. So the prohibition on the use of the drugs in the really the kind of late 60s and 70s and so on was not without cause. And we just see in the case of cannabis, for example, which is a drug that's continued to be used, that there are a minority of people who become extremely unwell when they take cannabis, and who would be much better off had they never taken cannabis. It's not to say everybody who takes cannabis becomes unwell, but there are some people who are vulnerable to the effects of that. And so I think it's very important that we have a cautious approach to this, because the first principle of medical ethics is primum non nocere, first do no harm.
I think some of the enthusiasm stems from the fact that in the psychopharmacology world there is a sense of stagnation, that we're sort of very much dealing with the same therapeutic options over and over again. So I think as a result, whenever we have a new sort of field of research, I think, like you said, I think exhilaration is a danger there. And I tend to take the viewpoint that, yes, it should always be about sort of very, very cautious, conservative progress, but at the same time progress answering the questions that need to be answered, so that we're actually in a position to make the correct decisions and maybe change policy in the direction that the data is suggesting.
Yes, that's right. But I think what's really unique about the whole topic of psychedelics is the enthusiasm that its advocates have. And I think the reasons for that is because the drugs are so powerfully transformative of experience.
Mm-hmm.
And so there are many people who've taken the drugs and feel that they've made profound personal breakthroughs in the types of their understanding of the world, the types of experience have been available to them, their ability to form relationships with other people, attaining a new sense of themselves, perhaps feeling that sort of ancient injuries have been put to rest, and so on. And so, and actually also, not least, because people who take psychedelic drugs, often the nature of those experiences evoke religious or religious type interpretations of their significance. So we're often dealing with a kind of cosmically exalted sense of the world resulting from these experiences. But actually, from that point of view, Jung made an interesting comment once. He was asked, this really must have been in the late 50s, early 60s, after the Albert Hofmann's accidental discovery of LSD, whether he would take psychedelics. And his answer was along the lines of, in order to take the drug, I'd need to feel able that I could integrate the conclusions of the experience into my way of life, into my adaptation to the world. And that's a very fundamental question, because if the use of these drugs occurs outside a context which has resources to make sense of them, then in actual fact the outcomes can be highly idiosyncratic and often very unhelpful to people, a source of profound confusion and precipitating people into mental distress.
Yes, I heard that he said something along those lines. I remember him being quoted as saying something like, beware of unearned wisdom.
Yes.
That there are sort of ideas or ways of thinking about the world or ways of looking at the world that you might not be ready for. And
yes,
when psychedelics introduce you to those ways of looking at the world, it can actually have a traumatic effect if you're not in the right state of mind.
Yes, indeed, yeah.
I think another reason for the enthusiasm around them is the fact that it would look like, were they to be introduced in a medical context, it would be quite short term. So it would be one or a few doses, as opposed to many mainstream psychiatric drugs which are prescribed chronically for months or even years at times. So I think that is part of the appeal, and sort of relatively few physical side effects and the relatively low danger of physical toxicity as well, I think is quite appealing. But also probably the fact that these drugs aren't purely, like we alluded to before, these drugs aren't a purely pharmacological intervention. They certainly act pharmacologically, but they also seem to be, a psychological intervention to a degree, depending on the context in which they're taken. It could be a social intervention as well. And then some would argue that it could be a spiritual intervention.
Yes.
Speaking a bit more broadly, not just about acute religious experiences, but spirituality in general. Where do you think we are in the West in terms of our relationship to spirituality? Do you think we need more in these very, very rational times?
Well, I mean, that's a very profound question. I think it raises the even actually the terms in which the question is set up merit reflection, I think. Spirituality as a term is not an agreed term, actually, in terms of what it means. So some people talk about spirituality as something which is very tied into religious experience, is anchored within religious observance. That's certainly the traditional use of the term spirituality over the centuries. But I think in the context of secularization, spirituality has been used as a way of articulating human beings finding a sense of their place in the world, which is in some way uncoupled from traditional religious faith. That's a very new application of the term spirituality. It's only really arisen perhaps within the past 100 years or 200 years at the most, probably the past 100 years.
So it's kind of something to occupy the space between pure secularism and more traditional religious practices.
Well, you can think about it. So again, there are many different spiritualities that people advocate. But if we think about fundamental questions, who am I? Where do we come from? Where are we going? Then many people feel that the answers provided by science in themselves are not sufficient to provide fully satisfactory answers. And so there is a question also. Science is very good at causal explanation. It can't explain everything, but it's been very successful explaining big bits of the world and little bits of the world. But then the question of how should I live and how should I relate to other people? What is my place within this world? What are the sources of value in this world? Are not dictated by science, and it's not the job of science to do that. So I think it's understandable that as religious observance has declined for many people, that there is a perceived gap that people want to explore and address and find ways of resources to draw upon to help navigate the project of life.
Mm-hmm. How do you feel about it personally, having studied theology at Cambridge and then later becoming a psychiatrist? Do you have a relationship with spirituality or religion?
Well, I'd say that I have relationships with spirituality and religion. So I don't profess a specific religion, but I have certainly have a sense of religion. I was brought up as a Roman Catholic, so I've got that background. But through studying theology and religious studies, I studied comparative religion, so I studied Hinduism and Buddhism. I have spent a lot of time in the Middle East, so I've had through personal contacts. My wife's Lebanese, a good friend of mine from childhood is Pakistani origin, is from a Muslim family, and so on. I've had a great deal of contact with Islam, and I think the observation I'd make is that the term religion is another high-level abstract noun, which is an umbrella term, and it accommodates actually a huge variety of practices and sensibilities. And I think the notion of what religion is being really taken over by fundamentalism all over the world. And so what we spend much of our time encountering now is the most destructive and defensive manifestations of religion, which also at the same time give religion a type of bad press. And the elements within religion which are much more at home with unknowing and place a much greater emphasis upon love and a much greater emphasis upon human flourishing and coexisting with people, that those forms or manifestations of religion are much more, they're still present, but they're under pressure. And in this kind of information war that we're wrapped up in now, they've been somewhat eclipsed. And the people who are shouting loudest in control of religions are doing their best to suppress and eradicate those manifestations within those great traditions. So there's a great contest going on in the world at the moment between different forms of sensibility. And what I would say is that it will very often be the case that if we use a high-level noun like religion, that subsystems within the religion of one religion will share much more in common with a subsystem with another religion than between the more fundamentalist manifestations of co-religion. And indeed, the fundamentalists are actually very similar to each other.
Mm-hmm.
If you put a Hindu fundamentalist next to an Islamic or Christian or a Catholic fundamentalist, and even next to a sort of neo-fascist, they're actually quite similar. They're all angry.
Mm-hmm.
And
they're all very ideological.
Ideological, they're all angry, they all hate people.
They're all
scapegoating.
They're all very totalitarian, so they're well encapsulated. And that's kind of a word we use to describe delusional thinking as well, when it has very specific boundaries and it's self-contained.
Yes, although I would hesitate to use psychiatric. I would hesitate to apply psychiatric concept to that. I think in some individual instances, clearly people's mental health problems motivate an interest in extremist ideologies. But I think as a human phenomenon as a whole, it falls outside the general scope of psychopathology. It is just part of, has to be understood within terms of history and, if you like, normal psychology, political psychology, and so on. But I think from a personal point of view, I think it's clear that I think really the greatest challenge that we are facing at present as not just a society, but society as a whole, humanity as a whole, is is resisting the pressure to fall into split-off camps who perceive themselves as at war with everybody else. There are very strong political pressures encouraging people to do that. The internet's got very wrapped up with this. But I think from the perspective as a human being, I think it is important to maintain our sense of common humanity and our kinship with other human beings. What's recognising it's in the nature of human beings that there will be variation and people have different ideas about the world. That has always been the case. And in the main, we can coexist well with that and we can flourish together with that. And I still think that remains possible and available to us as a species. But that will not be the case if extremist ideologies gain more and more traction, as appears to be happening at the moment. And if politicians also do not stop appropriating elements of those ideologies in order to make people angry and frightened and vote for them. Mm-hmm. So I think there is a collective effort. From the point of view of my own perspective, I think in terms of finding your place in the world, you can think now that if it is the case that many people fall outside a well-defined tradition, it's still the case that you can learn from traditions and you can learn from practices that have been explored and developed over thousands of years, or perhaps even more recently. And I think within that context, I think a recognition of the limitations of our knowledge as human beings is important. But within that, an ability to deepen our sense of relationship with the world and other people is important too. And so I think we're talking really, in theological terms, I think we're talking as a kind of triangulation really between traditions which are called apophatic theologies, which essentially involve a reluctance to make positive statements about the nature of the ultimate or God, but equally recognize that we are embedded in something far larger than ourselves, to which we are related. And within that, that's closely related to different types of mystical practice and sensibility. And here I think, again, the ability to attenuate a strong sense of self and be more open to the world as a system of relationships is important. But then I also think that elements of atheism, the skepticism of atheism and the challenge to overly concrete ideas of the ultimate is an important corrective. And so I think it's about having a kind of being open to a dynamic interplay between the many ways in which sensibility can be fashioned and how we can learn from other cultures. And I would be talking, but you talking about many traditions within Hinduism, within Christian, all mysticisms actually articulate some form or other of this, Islamic mysticism, Sufism, certainly within traditions within Buddhism. but actually also within the secular as well, so within traditions of romantic poetry and other traditions as well. So I think we just have to open ourselves and be in dialogue with the world, really, and dialogue with history and the products, really, of centuries of reflection about the nature of human beings and their place in the world.
I think people are immensely afraid of contradicting ideas, often unconsciously. So whenever they encounter new ideas of modes of thinking that contradict their worldview, they find it very frightening. So their tendency is to immediately put up defenses or barriers, often to an irrational degree. And I think the ability and the willingness to embrace contradiction is really something that we're blessed to have available to us as human beings, because it's really that richness of different ideas which you mentioned, which makes life so interesting, and ultimately I think which allows us to make as much progress as we do as a species. One thing you mentioned earlier, which really resonated with me, was the idea that within psychiatry we don't really have a concept for mental wellness, for thriving. And I actually wonder whether this isn't a larger problem within Western medicine in general, that we tend to operate in a kind of illness paradigm where we wait for people to become sick, and then we take steps to make them healthy, as opposed to a paradigm where we as a society try and build in structures to the way we live to make people healthier, whether that's in a mental sense or a physical sense, although really you could say that they're one and the same. Do you think as psychiatrists, or just even as doctors in general, we should be thinking about taking steps in that direction, in a direction of encouraging health and resilience versus always sort of putting out the fires of illness?
Yes, I mean, in fact, it's hard to disagree with that perspective. I think the challenge is really to do with what should we be encouraging, what's the best way to increase resilience. And also, I think the position we're in, we have to strike a very careful balance as doctors and health professionals, because I think one of the advantages of psychiatric practice and the medical orientation is it doesn't dictate to people how they should live. And I think one of the that is to say that if somebody becomes ill and distressed and disabled, then there are grounds for intervention. But apart from that, doctors are not tasked in the main with directing people how they should live. I mean, there is, of course, we do have seen this increasing shift towards health promotion and preventative medicine. So, of course, there will be dietary advice given, there will be advice about drinking, there will be advice for people with diabetes about sugar consumption and so on. So doctors have a more health prevention role in that respect. But I think what we're talking about here is less about the prevention of specific diseases, but perhaps more about what can we recommend to people to have a more, to flourish more, to have a more positive experience of their life. Here we're getting into the area of what some people call positive psychology as well. And again, I think in general terms, I think that it is good to shift the emphasis of mental health services to helping people to not become unwell in the first place, to increase resilience. I do think there are questions about how prescriptive we should be, because I think it's important to allow people to live their lives as they want to. And so the other question there is, to what extent should we have a more fully developed theory of individual psychology which locates an understanding of illness within that? And so I alluded previously to Jung's earlier ideas about integration. So Jung was an interesting figure in psychiatry because he actually did have a positive conception of what amounted to personal development and mental health. He had a notion of individuation and integration. He viewed the psyche as a self-regulating system. So I think these are useful concepts, but the problem is, as soon as you try to specify more detail to them, then in actual fact you can overcommit yourself to a very particular notion of what a human person should be. And I actually think that we, as a society, it's important to allow a certain latitude for people to be as they wish to be. Or so we shouldn't be. So there's some kind of balance to strike here. So it's not just a question of theory, of what's the best theory of how to promote the absence of illness and a positive experience of life. There's a debate to have which extends beyond psychiatry about what counts as a good life. I don't think psychiatry has all of the resources to answer the question of what counts as a good life.
So it's fundamentally a philosophical question.
Well, that's certainly a component of it, but actually it's also a socially negotiated question as well, which will vary. So what counts as a good life for a religiously observant person is different, in certain important respects, for what counts as a life for, say, somebody who isn't religiously observant. There are ethical differences, ethical orientations of the world, which will make a difference to how people live. The other point to make is that it's really important not to view psychiatry itself in isolation from the broader social changes that need to occur to promote well-being, because there are so many arms of policy which have a bearing upon well-being: education policy, social policy, employment, work conditions, and so on, which have a huge impact on how people are. And by the time that somebody gets to see their doctor, they're already been sort of buffeted and constrained and influenced by all sorts of their broader social environment. And we don't engineer that. I think psychiatry is part of the conversation, but I think it's a much broader conversation that has to go on in society about what promotes well-being.
And it has an impact on the things you mentioned on physical health just as much as mental health, these
Absolutely.
social factors, etc. Yeah, I mean, it's certainly, it just shines a light on how complex these issues are. Just to wrap up, because I'm conscious of your time, one thing I'm going to start doing now, which I'm stealing from my friend's podcast, shout out to Good Faith podcast, Christian Perugin, is I'd like to see if you have a question for me, actually. I've asked you a lot of questions.
Yeah.
I'd be interested to know, from your perspective, what questions do you have for a training psychiatrist?
Yeah, what's your sense of where the discipline is now? What are your hopes for the future? What would you like psychiatry to look like in 10 or 15 years' time?
That's a good question. I think actually it revolves a lot around what we've been talking about. I do think we need to think a little bit more broadly about what mental illness is, to move away from a more reductionist, scientific, purely medical model, and to maybe a more integrated model, I suppose you could call it, one that thinks about facets, so be they sort of more philosophical, psychological, social, etc. I, from my point of view, I get the impression that psychiatrists in general had a wealth of psychological and philosophical knowledge up until the point where psychopharmacology became very mainstream. And then what I think may have happened is the arrival of these drugs on the scene was such a significant event, and it pushed things so hard in the sort of medical, biological direction that I worry that we've abandoned these principles of working in, for example, a psychotherapeutic manner. And I think as a result, we've lost a lot of depth as a profession. So making strides to go back in that direction while, using the psychopharmacology, which is undeniably very useful. Interestingly, I see psychedelics as a very, very interesting confluence between the biological and the psychological, like we mentioned. It seems like it's a sort of a meeting point between these different ways of thinking about the world. And I guess what I would hope is that encourages people to be able to think on these multiple levels of analysis simultaneously. So that's a bit rambling, but that's kind of my loose thoughts on the subject.
Yeah, so I think I agree with all of those sentiments. That all of that sounds right to me. One reflection I would have on that is actually the, if you like, it's the broader location of psychiatrists within health services. And in my medical career, one of the things I notice is how rationed healthcare has become. And I think rationing runs very deep in healthcare, and it has a huge impact on the time we have available to spend with patients and the level of understanding, individualised understanding that we can bring to bear. And I think until I think it is fundamentally, there is a question of resources here. In order to provide better healthcare, we need more doctors and more time to spend with people. Because at the moment, our services are geared towards dealing with people with the most extreme, most profound distress. And there are many, many people who are struggling, who we're not able to help because they don't meet the criteria for access to services. And so I think I agree with all of your comments, but I think again there is a broader political discussion to have about the availability of resources and the design of health services.
Yes, I mean, just to make it really concrete for anyone who's listening, most cases, the majority of cases of depression, for example, are likely to be seen by the GP, by the family doctor. And in general, they only have 10 minutes or so, maybe 15 minutes to see a patient on average, let's say. And I think to anyone that's trained in mental health, they would know that to properly tease out the different aspects of a person's life when they are presenting with any kind of mental health condition, 10 minutes is so insufficient, both to get a sense of what the problems are, but also to collaborate with the patient to try and design an effective solution. And I think, yes, so because the most severe cases must take priority, it's rare that a patient sort of with, for example, mild to moderate depression would be seen by someone, who's an expert, who's a psychiatrist in a secondary care context and actually get the help they need. And often it's these sort of reasonably functional patients who have the most potential actually to make recovery and progress and improvement. So yeah, I mean, you can't not mention under-resourcing when you're talking about healthcare nowadays.
Yeah, so I agree with all of that. It's resourcing and how we design services as well.
Mm-hmm. I just have one more question. Is there anything in particular you do to look after your own health in general, physical health, mental health? Are there any sort of daily practices that you do?
Yoga.
Mm-hmm.
Which is, I've done yoga on and off for years. I'm not actually a great yoga athlete, but you don't have to be. It's a good thing to do, and I think there's an aspect of it which aligns very well with meditation, which is also a very good thing to do. So I've meditated on and off over the years. It becomes harder to meditate, of course, when you become very busy with family life and children and so on. But anyway, that you can do that. Also, I think actually walking is a very good thing to do. So I try to walk around London. I walk in the countryside as well, and I think it's good. It's a good psychophysical practice, well-being practice. But they're two things that I do. There might be more.
Thank you very much, Dr. Deely. It was great to hear your thoughts on all these complex issues, and I'd love to have you back at some point in the future.
Great, it's been an absolute pleasure. Thank you very much, Alex.
Thank you.
You have been listening to the Mood for Thought podcast.